We will now move on to the next session that we have on our agenda, and it's an entire afternoon of drug reviews and therapeutics. And for this, to start off and kick the proceedings along, we have our very first speaker, none other than Dr. Shashank Joshi, who is now going to take up the first talk in the drug reviews and therapeutics session. And Dr. Shashank is going to talk to us about reviewing the evidence, glycemic control and weight loss with Dapagliflozin. And absolutely, I'm sure that Dr. Shashank Joshi needs no introduction at all. And he is a very good friend, excellent speaker, orator, great academician. And his bio data will run into several pages. So I won't go into the details because everyone is aware. And I am now going to ask Shashank to please proceed with his talk.
Thank you, Neeta. Thank you, Sanjay, Neeta, Anjali, everybody, for keeping this. You will have to allow me to share the screen, please. Hello?
Yes, it's done.
I'm not able to share the screen. You'll have to.
Are you enabled now?
Yeah. Can you see my slides?
Yes, I can.
Yes. So this is a talk. I have duality and conflict of interest for this talk because it's with micro labs, and I also have a duality and conflict because all the four actually SGLT2 inhibitor companies have some relationship with me, either as a speaker bureau, advisor, or research trials. So thank you, Dr. Agarwal, Dr. Deshpande, Dr. Sarda, Dr. Bhatt. We are going to review evidence on glycemic control and weight loss with Dapagliflozin. And it is going to be in context because Dapa now has become generic as far as India is concerned. So we all know this very well. Diabesity is the predominant driver of type 2 diabetes in India. And we know its complications like cerebrovascular disease, cardiovascular disease, micro and macrovascular events, renal complications, dementia, cancer, and even eye disorders are well known. We also know that in the Indian scenario, generalized obesity is around 58% when we use the Indian cut points, and combined obesity of diabetes and obesity is around 53.4%, and abdominal obesity is around 81%. We also know that clearly the risk with the BMI going up, just like A1C going up, the risk of prediabetes and diabetes goes up. And the lifetime risk of progression of prediabetes to type 2 diabetes is increased by BMI data and waist circumference data. The Rotterdam study showed us very early, and we know that the age of onset of prediabetes was around 10 years later for adults with normal weight strata compared to the obesity strata. Now, we as an ethnic group, Asian Indians, are more at risk both for diabetes and obesity. And probably the Asian adults have a 5-year risk of progression to type 2 diabetes within years versus Caucasian. So we have a malignant transformation from pre-diabetes to diabetes. And the prime driver in that is probably obesity. Because we know obesity drives inflammation, which is chronic, in the adipose tissue, liver, hypothalamus, pancreatic islets. And eventually it leads to systemic insulin resistance and beta cell dysfunction. And that's really the core. We also know that we need to do a tighter glycemic control in people with type 2 diabetes and obesity, because we know the diabetes patients, the prevalence is high, and most of them have a very poor diabetic or a glucose control. And obesity is a determinant of poor glycemic control or metabolic control. So glycemic control in obese patients with type 2 diabetes is very key. And in order to prevent microvascular complications, because it significantly affects quality of life as well as outcomes. So currently we have a lot of challenges with weight gain during anti-diabetes therapy. We know considerable amount of anti-hyperglycemia therapies have considerable effects on patients' weight, and careful consideration for weight loss therapy in people with diabetes and obesity is now the standard of care. For example, glitazone, sulfonylureas, glycides, insulins all cause weight gain. We know gliptins, fixed ratio insulin, GLP-1s, and various other therapies are weight neutral. And it's only that the ones which promote weight loss or maybe weight neutral are metformin, SGLT2 inhibitors, GLP-1 receptor agents, alpha glucosidase inhibitors, and amylin myelomimetic, in which top on the pecking order is SGLT2 inhibitors. In fact, it's the era of SGLT2 inhibitors. And clearly we know that an OHA which improves glycemic control and reduces weight is clearly the need of the hour. So SGLT2 inhibitors have arrived, and their role in weight loss is dual. they essentially have an impact on body weight in diabetes through two mechanisms. One is by increasing urinary glucose excretion, they cause caloric loss and weight loss and reduction of fat mass. And second is by reducing the insulin to glucagon ratio, they increase lipolysis and they actually melt fat and they cause weight loss and reduction in fat mass. So clearly, and without affecting the lean body mass. So this is very, very significant that clearly they shave off the fat through the lipolytic mechanism by reducing the insulin to glucagon ratio, and by causing simple glucosuria and calorigenesis, they are able to lose weight. So Asian type 2 diabetic patients with abdominal obesity, the clinical recommendations are very clear cut. And it is recommended to promote weight loss, to reduce visceral adiposity in Asian patients with type 2 diabetes and obesity. So it's a recommendation from Asia to promote weight loss. We can use SGLT2 inhibitors. In fact, 2/3 of the SGLT2 inhibitor induced weight loss is attributable to reduction of body fat mass. And it also reduces waist circumference, ectopic fat deposition in non-adipose tissue, improves adipose tissue function, quality of life, and patient reported satisfaction. Clearly, some time back, this was an evidence-based consensus position statement, which was come out with several authors. And you can clearly see that weight reduction due to loss of fat mass is primarily from the abdomen rather than lean mass. It's not only the weight loss and the glucose control, but it's durable, it's sustainable. So both the glycemic control, body weight and blood pressure reduction with CV benefits and renal protection is sustained without any risk of hypoglycemia. And there is a persistent calorie loss. So clearly this is sustained, durable glucose control, blood pressure control, cardiorenal control, cardiometabolic control, and that of course Gagan Priya will talk on it. But my predominant focus today is on weight loss and reduction of body weight, more visceral fat mass loss than substitute fat, reduction in insulin resistance and improvement of beta cell function is what SGLT2 inhibitors do. So in the Indian patients, we know they have more abdominal obesity and visceral fat at any given BMI, and SGLT2 inhibitors by evidence base in India reduce that. The higher waist circumference and higher waist to hip ratio is reduced. The lower adipokine and higher plasma leptin levels are reversed. The lower rate of glucose disposal is modulated and increased, and the beta cell function and insulin resistance is improved. Also remember, SGLT2 inhibitors in combination therapy have a huge impact. For example, SGLT2 inhibitors combined with drugs which reduce food intake like GLP-1 receptor agents on energy intake and energy expenditure and their compensatory effects. Clearly, you can see here that they can have a greater weight loss in two ways. They increase food intake by evoking energy loss during SGLT2 inhibitors, and that can be partly prevented by appetite reducing therapy. So clearly, you can see the equations on both the sides of the curve. The SGLT2 inhibitors will increase the EE via glucosuria, and the food intake inhibitor like a GLP-1 receptor agent will decrease EE via cellular metabolism. And the combination of the two is clearly synergistic. And the reduced cellular energy expenditure occurring after weight loss achieved by the GLP-1 receptor agent is balanced by the urinary caloric loss secondary to glycosuria. So these complementary mechanisms of actions again make it very attractive for weight loss. So what do the guidelines say with diabetes and obesity? Clearly, if you see the ADA 2021, obesity management can be a progression from pre-diabetes to diabetes and is highly beneficial. In fact, off-label, many of us in pre-diabetes with obesity are using the SGLT2 inhibitors after it has become generic. There is modest and sustained weight loss, which improve glucose control and reduce the need of glucose-lowering medications. And this is the evidence based on that. And it is pretty compelling as the BMI goes up. Clearly, beyond diet, physical activity, behavioral therapy, when choosing a glucose-lowering medication, one must compare the impact of that medication on the body weight. And after metformin, SGLT2 inhibitors is clearly there. Of course, there are other agents also, but they are minimalistic in that recognition. If you look at the American College of Clinical Oncology ACE recommendations, they again say it is individualized therapy, try to reduce body weight by 5 to 10%, and probably SGLT2 inhibitors have a glucose-uric effect with reduced A1C, weight, and systolic blood pressure. So clearly they are there. The RSSJ ESI therapeutic whale was made in 2020 when the finance F feature SGLT2 inhibitors were not generic. And now we know that it is generic. So obviously, I think it's the only anti-diabetic agent with this feature with cardiorenal protection, weight loss, and is economical as well. Obviously, the efficacy is something which we need to establish. Is there evidence base for DAPA? with established type 2 diabetes for efficacy on weight loss. Clearly, you can see that the clinical considerations are clear-cut. It lowers glucose independent of insulin action. It has a sustained effective glycemic control, reduces body weight, low risk of hypoglycemia, very well tolerated as monotherapy or as an add-on, reduces blood pressure, rate of cardiovascular death and heart failure, hospitalization, and progression to renal disease. This is data whether you add DAPA on monotherapy, add on to metformin, SU, MET and SU, gliptin with or without metformin or insulin. It is consistent. If your A1C is 8 to 9%, 0.5 to 1% drop in A1C in DAPA has been observed consistently. So the clinical trial data and the real world data, both are consistent. Both the data, the RCT data and the real world data, shows that A1C drops by around 0.8, 0.9 or 1%, as well as the weight loss is also achieved. So Dapagliflozin achieves a comparable reduction on A1C and weight in real world practice as seen in randomized clinical trials, and we have seen this in clinical practice. And it also has a very, very important impact on energy metabolism, which I was talking about. This is a RCT which was done, and you can see here in this RCT, clearly, Go et al. Showed body weight was significantly reduced by dapagliflozin versus placebo. And in 5 weeks itself, within 5 weeks, there were metabolic adjustments mimicking caloric restriction. Fat oxidation was increased. Hepatic and adipose tissue insulin sensitivity was improved. And 24/7 energy metabolism was improved. So clearly you can see that in real world practice, it achieves quick A1C control. 80% have more than 1% A1C reduction, and 65% show both an A1C drop and a weight loss. Clearly, this data is consistent. It maintains glycemic control and weight loss over a period of time. That's also very crucial, that it must last. It should not rebound back, and that is very consistently seen. And the data is consistent in Indian patients also. Dr. Vijay Vishwanathan's study I'm quoting here, where he has shown with DAPA, clearly it is a sustained effect not only on A1C, also on the BMI, body weight, and waist hip circumference. So clearly now we have data from that study, which was an Indian pan-India study where DAPA was well tolerated. A1C and body weight came down in 6 months, and it achieved a significant weight loss. And various other replicative studies have also shown that it not only causes weight loss, but if you study the body muscle mass and muscle fat content, it is only the fat mass which is lost without reducing muscle mass. So this is a very, very crucial study by Sugiyama et al. From Japan, where they studied, because the big fear is that people suddenly will say that we have lost a lot of weight, we'll lose muscle mass, but muscle mass is preserved and only fat mass is. What is unique about this molecule is that it also inhibits the hepatocyte death, because clearly it induces the reversal of NASH. You can see our SGLT2 inhibitors reduce inflammation, tag accumulation, and tunnel positive apoptotic cells in the hepatocytes. They reduce the insulin resistance in the liver, reduce the de novo lipogenesis in the liver, and increase the fatty acid oxidation in the liver. They reduce the inflammation, the reactive oxygen stress, as well as response, and hepatocyte death capsase 3 is reduced. So clear-cut down regulation is seen, and fatty liver, it chops off the fat. This was a RCT with DAPA, where hepatic and visceral fat was clearly reduced in a 12-week study, and this is some compelling data which is there. Also, when you add it with insulin with OADs, usually it is very well tolerated, body weight is reduced, and many a times we are able to chop off the insulin as well. Also, this is a meta-analysis where you compare 2.5, 5, 10 milligram and 20 milligram of DAPA. You can see the weight loss reduction is consistent. So you can see it's all on the left side favoring dapagliflozin, and clearly you can see that weight loss reduction is dose dependent. So higher the dose, the better is the dose reduction, and body weight is significantly reduced in people with different doses of SGLT2 inhibitors, and it is statistically significant dose dependent. Clearly you can see that weight reduction is significant, it is compelling, and it is impressive. So the key insights which we learned today is that SGLT2 inhibitors on body weight is an important component for obese people with type 2 diabetes with consistent weight loss, which is vital for effective management. And that is why SGLT2 inhibitors have become universal agents. I call them versatile agents and universal agents now. They probably might replace metformin. The data is coming up so much that the cardiologists and nephrologists have already taken them away. And I'm certain that in times to come, the obesity experts will also take them away, because they are originally diabetes agents. But the data is so overwhelming that particularly Asian patients with type 2 diabetes, whether in combination or in monotherapy, they promote weight loss. DAPA maintains glucose and weight loss, which is sustained over a year or two. And early use of DAPA enables not only better glycemic control with weight loss and can become a standard of care in routine practice. Thank you for a patient hearing. Thank you for a patient hearing.
Thank you so much, Shashank, for excellent deliberations.
Thank you so much, Shashank, for excellent.
One second. Yeah, my question to you, Shashank, at this point is, since we're talking about weight loss with dapagliflozin, if we had to actually use an agent for weight loss with good glycemic control, obviously SGLT2 inhibitors are the choice nowadays. But do you see any difference between the weight loss effect of different SGLT2 inhibitors?
So that's a good question, Nita. Is it a class effect or is there a differential effect of different agents?
Yes.
So currently, if you ask me overall, if you look at the SGLT2 inhibitor ability or capacity, you have CANA, which is the broad spectrum, then DAPA, which is intermediate spectrum, IMPA, which is restrictive spectrum, and REMO, which is again a broad spectrum. So from the SGLT2 inhibition perspective, it doesn't impact weight loss so much. If you ask me, more or less, we would expect it to be similar for all. The data is best generated in terms of liver fat, visceral fat, RCT data, Asian data with DAPA. So when it comes to evidence base, it is most documented with DAPA, but I would not be surprised if it also is replicated by other agents. See, each SGLT2 inhibitor has its own molecular nature, and each one of them will have some impact. Now, one thing is sure that CANA 300 mg was supposed to start a study called CAN-FEN study for obesity. And they had to abandon the study because, CANA got associated with amputations.
Right.
And that is why they had to take up the study. Dr. Panikar and myself, a couple of years back in JAPI, published our own data from Lilavati on various SGLT2 inhibitors. We found that by and large weight loss was similar, but CANA 300 may have a little more weight loss, was what was observed. But currently, as I said, CANA has its own challenges with adverse events. And DAPA is probably having much better data on kidney and heart. And that is why probably the preference as a universal agent on weight impact is better. Also, the energy metabolism studies, Nita, which I alluded to, have not been replicated with other SGLT2 inhibitors. With CANA 300, there were 2 trials which were attempted. Both the trials showed weight loss, but no energy metabolism study has been documented. Fatty acid oxidation studies are universal for all the 5 SGLT2 inhibitors, including dapagliflozin and dapagliflozin. But those are early phase 2 trials. So from a data standpoint, DAPA has an advantage. DAPA has been the agent now, this is a SGLT2 inhibitor year, if you ask me. Next year might be a semaglutide year. So and DAPA has become generic. It is easily available and accessible to most of our patients.
Right. There is one question from the audience. Dr. Sunil Mewada wants to know, can DAPA be given in non-diabetics for weight loss?
So off-label, whether it should be given or not in a research trial, it can be given. I have used it off-label in pre-diabetics. But in absence, normal glucose, I may not use it. But our cardiology colleagues and nephrology colleagues, now it's actually approved to use it for other indications. So I am certain that SGLT2 inhibitors will find a space in the obesity space as well. They will get very close competition, and Nita will agree with me, from oral semaglutide. Right. Only thing is, oral semaglutide does not have CV outcome. The SOUL study is a soul searching study. If that SOUL study comes positive, then they will be in neck to neck with an agent like DAPA. In absence of the SOUL study, the current agent of choice probably, which is affordable, accessible, available, is probably DAPA. It's worth trying, but I would not say, because you also remember every agent which works has adverse events. So it can cause genital mycotic infections, it can cause urinary infections, it can lead a patient into euglycemic diabetic ketoacidosis. A lot of our patients do these fat diets like keto diets. So it can also be deleterious at times. So you need to be a little cautious and careful when you use some of these agents.
Right. There's one question that I would like to ask you, Shashank, and we have all seen in practice that, and in the clinical trials, that it's about 3 kg weight loss is what we expect when we start, and it is pretty much durable. But then there is a subset of patients who lose far more. And we have also documented that. So can you explain why some people lose so much more weight? What could be the determinant so that it's easier for us to focus on those patients for weight loss?
So Nita, this was studied by Sugiyama et al. and this was studied in that study. I would send you the full text of the paper. Two things. See, the glucose-urea is same for everybody.
Yeah.
The only difference is the fatty acid oxidation and the lipolysis. Some people will have more lipolysis compared to the others. So a patient A may lose 11 kgs, patient B may lose 3 kgs, patient C may lose 1.5 kg, patient D may lose 7 kgs. The differential in the weight loss is accounted by the lipolytic pathway. And lipolytic pathway is probably the differentiator, but this is again early. I cannot say it with certainty.
Yeah.
This is what the Japanese literature says. And it's an interesting concept because we have these responders or super responders, as you are saying, which have much more weight loss compared to the others. Probably their ability to do beta oxidation is more robust. There, as there is another company which propagates now a concept of metabolic flexibility.
Yeah.
Their mitochondria are more, if you talk to Dr. Nair, my mentor, he will say that their mitochondria are more metabolically flexible. Just like we need muscle flexibility, there is mitochondrial flexibility. It could be a postulate. But these are all postulates. Mind you, these are hypothesis generation. These are postulates. But these are interesting postulates. So I think there are super responders. And I have also seen in my practice, some people lose dramatically up to 10 to 12 kgs.
Yes.
And they actually come and tell us that, sir, I have now dried up. Everybody's saying I'm sick.
Okay.
So they don't want the agent sometimes.
Right. Yes.
May I have one question?
Yes, Anirban.
Yeah, Dr. Joshi, the one small question, because we many times face from our physicians that because of the this generic data, so many generic data available in the market from different Indian companies. So what is the difference between this with that of the innovator company? Whether they are same as far as efficacy is concerned, and whether they are same as far as their safety is concerned. What is your opinion?
According to me, I don't see any difference. This is a very honest question and honest answer. Okay, though there is a lot of duality and conflict of interest in all this, but I would be very honest. I think, at a molecular level, these are not biosimilars like biopeptides. These are easy to make. So I don't see there is major difference in all this. People will score brownie points, but I doubt it. We all know it now, and let's not get there. Sanjay and Neeta will throw me out from here, but I don't think there's any difference. I'm being very honest about it. Unless Neeta has a competing point, I think that's it.
No, that's fine. Thank you. So I don't see any other questions in the chat box. Thank you, Shashank, for a wonderful session and taking us through the glycemia and weight loss effects of dapagliflozin. Thank you for being with us. Thank you very much.
Thank you. Bye-bye.